Welcome, everyone, and thank you for joining us today. I think we're just going to give everyone a few more minutes a couple more minutes as people are joining. And Stanley, one of our panelists, I believe you have joined us. Stanley, are you able to hear me okay?
Yes, I'm available.
Wonderful, Stanley. Welcome. We'll just give everyone a minute more. Thanks, everyone. Welcome, everyone, and thank you very much for joining us for this webinar this event on Slipping Away, a review of humanitarian capabilities in cholera response. My name is Manisha Thomas. I'm going to be the moderator for the event today, and it is my pleasure to have all of you join us, and hopefully we will have others joining us as well. We have a number of people who've registered, so I think they're just slowly trickling in. This event today is jointly organized by Humanitarian Outcomes with the UK Humanitarian Innovation Hub and ELRA, and thank you very much to ELRA for hosting this event today. We're here to talk about the report with the same title, Slipping Away, a review of humanitarian capabilities in cholera response, which was funded by the UK Foreign and Commonwealth Development Office through its Humanitarian Innovation Hub. And huge thanks to Ben Ramalingam at the Humanitarian Innovation Hub previously, who had the idea. Ben has since moved into a different position with the British Red Cross. We have a number of the team members who wrote the report. As you can see, we've got Abby Stoddard from Humanitarian Outcomes, Nigel Timmons, who's an independent consultant, Ron Waldman, who's with George Washington University Milken Institute School of Public Health. They were all part of the review team that wrote the report. We've also got with us MJ Breckenridge, Paul Harvey, Glenn Tyler, and myself, as we could also come in and speak to it. And today we're going to hear a little bit from some of those, some of the team about the report, why it was written. And we have a couple of expert contributors and practitioners, who are going to be able to provide some reflections and comments on what they thought about the report, its recommendations, and where we might be able to go moving ahead. So we've got Raul Kamaju from UNICEF and Stanley Chitukwi from the Organization for Sustainable Socioeconomic Development Initiative, Malawi. So welcome to all of you. I would love to invite all of you in the audience to please introduce yourselves in the chat. I hope you can. We would love to hear where you're from and your name, so please do that. We also have a Q&A option, so you can add questions during the event, but we would love to hear you also maybe take the floor. We can promote you to a panelist when we get to the Q&A and hear your thoughts and reflections as well. What we'll do is first have a bit of a conversation with Abby, Nigel, and Ron in terms of the report and the findings before we turn to Raul and Stanley. And then we have plenty of time for you in the audience to engage as well. With that, I am going to then turn to you, Abby. Abby, as the team leader of the report, what prompted the study and what were the findings?
Hey, yeah, thank you, Manisha. And thanks especially for moderating today when you were an important part of the team as well, like doing double duty. Appreciate that. What prompted this study essentially was, sorry, I'm trying to advance my slide here. Was essentially a growing sense of alarm among public health entities and humanitarian entities on the growing concerning trend in cholera cases that they were seeing. So these were patterns of outbreaks starting in 2021 that last year kind of raised this alarm. And what we were seeing was there were a larger number of countries experiencing cholera, including some that cholera hadn't, was reappearing after many years, and as well as cases in countries where it was endemic, but in unusual sort of geographical patterns. So occurring in places, non-hotspot places, and also at unusual times of year, which were catching public health systems off guard. So you had this 77 actually % rise in numbers of countries, and odd patterns of geographical distribution. And then most concerningly, according to the data reported from countries, you were seeing a rise in overall case fatality rates. So cholera is a disease that should be survivable if properly treated, and treatment is relatively easy and inexpensive. And the commonly accepted threshold for deaths in cholera outbreaks is around 1%. So what we were seeing instead were some countries, including Malawi, reporting case fatality rates of maybe 3 and 4%. And so we need to caveat the data generally. It's difficult to get this data overall, and we'll be talking more about the data challenges later. But also when you look back over the sweep of this current cholera pandemic that we're in, which started in the 60s, the numbers of cases in countries are not unprecedented. But it's definitely moving in the wrong direction over the past several years. So this is why it was concerning, and why our partners UKHIH suggested that we do this as part of one of our rapid review series. So the purpose of these rapid reviews are to, over a short intensive period of desk-based study, look at an emergency, a new emergency, or a newly exacerbating crisis, and provide some analysis for decision makers. So cholera was the first time that we've done it for a global theme as opposed to a country, but we were very lucky to have a team which included public health and humanitarian cholera experts, and WASH experts, two of whom will be speaking a little bit later. But the overall patterns that I mentioned raise two kind of overall questions. First, why? Why is it happening? Why are the rise of cholera outbreaks and cases generally? And there's no one simple answer to that. There are multiple complex causes for why cholera breaks out. It happens often around conflict and dislocation. People migrating and moving into overcrowded urban areas. There are effects of climate change which contribute, and there's an overall crumbling of infrastructure that you see, lack of maintenance or lack of governance over WASH systems in countries, all of which can and have, I think, played a role in increasing cholera cases. But the focus for this study was more of why do deaths and case fatality rates seem to be rising? this was our focus, because as we said, whatever the causes of the outbreaks, and there are many and complex ones, when you have high case fatality rates, there's something happening with the response. People are not being found quickly enough or not being treated appropriately. So I'm just going to briefly touch on our findings, and then we'll get into more detail when my colleagues speak in a bit. So there are a number of obstacles to the overall strategic plan for cholera. In general, the Global Task Force on Cholera Control and their roadmap for 2030, I think most all of the experts we spoke to agree that it's a strong group, it's a strong strategy, there are sound plans. The problem is that the implementation and the execution of the strategy, the actual country level national cholera plans, have fallen down in the implementation phase. So if the aim of the roadmap is to reduce cholera deaths by 90% by 2030, I think we're a long way off from that. There are only 5 countries with these plans already designed, and they're in various states of review. I think only 2 are complete. And people generally say there's not the funding and the expert technical support needed to get these going. We're also seeing among humanitarian aid providers kind of perennial divides between the health sector and the WASH sector in terms of coordinating. And as probably everyone on this call knows, it's incredibly important for cholera that WASH and health work together. So there are issues in the coordination and making sure there are dedicated coordinators on the ground integrating these 2 responses. There are also just basic capacity gaps of the humanitarian system in terms of the numbers of people required to do a rapid response to cholera. Now, there's also many other kind of external obstacles. In Haiti, for instance, the violence has been preventing a lot of implementation of building treatment facilities or getting things going. But for there to be kind of a 3-month lag, as we saw, getting treatment going is a real issue. And there also, we heard again and again, just not enough people available for kind of surge responses or to be trained and used for outreach at the country level. And then, and I'm not going to speak too much on this, we see evidence both in our systematic literature review, but more importantly, from the interview evidence, that there seems to be a slipping of competencies and preferences and emphasis on basic cholera treatment. So a more heavy lean towards medicalized and hospital or facility-based treatment, et cetera, as opposed to your basic oral rehydration. So all of that is further complicated by, as I alluded to before, a real weakness in data. The WHO data has about 12-month lag time for the compilation of what they basically rely on as countries reporting their cholera cases and deaths. And it is very difficult to know what's going on. The practitioners we spoke to got their data from, they gathered it themselves, they got it from other partners on the ground, they got it from public health systems when possible, they tried to get it from different agencies, but there is a problem not only in the collection, but in the sharing of data that we saw again and again. There are also kind of basic incentive problems with data. There are incentives both for over-reporting in some cases and for under-reporting in other cases. So this remains kind of a real stumbling block to measure and manage the problem of global cholera. So I think I've covered everything I want to from an overall overview point of view, and I can toss it to Well, I'll toss it back to Manisha for our next speaker. Thanks.
Thanks very much, Abby, and apologies to everyone for that slight hitch we had with the chat, but it is working now. And it's great to see we've got a mix of people from different sectors, including WASH and health. So I think that point, Abby, about that gap and that perennial divide that we see, I imagine that people in the audience may have some thoughts on that as we're moving ahead. So please do keep introducing yourselves in the chat. If you have any questions, you can put them in the chat or the Q&A, and we will be coming back to those as we move along. Nigel, I'm going to turn to you. How do WASH practitioners view the capacity in the system, having previously worked for a big organization that did WASH and having been part of the team?
Yeah, thanks, Manisha, and hi, everybody. I mean, there was basically consensus from everyone I spoke to that there is insufficient WASH capacity. Now, this has been a long-term issue. MSF wrote some papers back in 2014 entitled "Where is Everyone?" and Group Who Are They did an analysis for the Global WASH Cluster in 2019. Then there was another paper published by ELRA, a joint effort between Tufts, Cranfield University, Oxfam, and ELRA looking at, and the Global WASH Cluster looking at capacity in 2021. And each report has shown a significant gap between the demands in terms of needs and the WASH capacity that's needed and the WASH capacity available. This has got a number of reasons. A key one is obviously funding, and there's a huge gap between the needs and the resources invested. In the URD study, for example, in 2019, it was seen that the average sort of actual funding compared to the sort of requested funding was 45% across the sector, but it actually varied from country to country, going down as low as 17% of needs in a particular country. And as a total percentage of funding to WASH, so not just humanitarian, but globally, between 2000 and 2015, there was a 50% fall in funding to WASH. Now, in recent years, there's been a small recovery in multilateral funding, but that's actually been undercut by the continued losses in funding to the WASH sector by bilateral donors and IFIs. Another thing that practitioners came up with a lot was the short-term funding cycles. So that meant an underinvestment in the infrastructure needed for WASH, which can be quite capitally intensive, certainly in the initial phases. But more than that, it meant it was difficult to maintain sort of surge capacity, retain sort of qualified people. Having access to experienced qualified people able to deploy and support people on ground was a continued challenge, and the short funding cycles made that difficult. And there was also a comment that, just post-COVID, there was just a huge stretch on the whole system. A lot of people were tired. And so it was just like relentless sort of thing after thing. I think another thing that respondents talked about was the disconnect between short-term and long-term approaches, Abby said in the introduction, and that's reflected both in coordination mechanisms and in funding instruments. So really there's a need for a both and strategy rather than an either or strategy. So too often there's either long-term funding and a long-term approach, or it's an emergency and we need short-term approaches. Well, actually both need to be complementary and work together. And in a way, we need to shift to a greater focus on outcomes. So, the sort of reduction in cholera cases, particularly case fatality rates, rather than outputs. So too often the focus is on maintaining, whether it's the humanitarian system or the development system, maintaining development partners or humanitarian partners. The intention can be to support the system rather than a real focus on the outcomes. And that's where donors can play a role in terms of how they fund to incentivize greater collaboration. Another key element that came through the research, I think, was an underinvestment in WASH generally, but an even poorer cousin is the investment in understanding context and behavior. So, the risk communication and community engagement. I think we all have our experiences of COVID, and we're all much more familiar with the challenge of maintaining proper practices over an extended period of time. We've all seen the debates over whether masks were or were not appropriate, and just how challenging shifting behavior really can be. And too often the messaging around cholera can be too simplistic. It's a hand washing message, but actually you really need to get into the nuance. There's an interesting study from DRC where women in the house tended to be responsible for hygiene and sort of cooking and things, but the household budget that determined access to soap and things was controlled by the men. And there was an assumption that cholera was passing in villages, but it turned out that there was a lot of cholera passing amongst fishermen communities because they were going out into Lake Tanganyika overnight to catch the fish. They were toileting in the lake and then also drinking the lake water. And so the transmission route was in the lake. And it's that kind of detailed understanding that needs to be there in order to make sure the messaging is appropriate and targeted well. Abby touched on timelines. It takes a long time to get a confirmed case. So some respondents said there was a need to move to a sort of risk-based approach. So rather than waiting for a confirmed approach, we know about cholera. We've known about cholera for over 100 years. So if we've got all the conditions and we're seeing increases in acute watery diarrhea, let's not wait for a confirmed case, but let's start. Let's take a no regrets approach and sort of double down on strengthening the anticipatory action, which at the moment can often wait for a confirmed alert. And so it's actually just faster response. The point of anticipatory action is to invest in high risk situations. And then finally, just sort of looping back to that sort of point around funding is, I think there needs to be a much greater increase in the profile of WASH. So other sectors, and you might say cash or perhaps social protection, would be much better at communicating to the wider sector the advantages of their approach, the policy commitments, the economic benefits, the evidence. And, there can be more that the WASH sector could do to sort of promote itself and make clear its significance, whether it's from an economic angle or from a health angle, and have more policy initiatives and webinars like this one, for example. I'll stop.
Thanks very much, Nigel. And I think it's how, as you said, there's a lot of things that we could be improving on. There's a lot of things that we've known about for a long time. Cholera is not a new disease, but how we're approaching it and how we're reacting is really critical. And as you mentioned, that data point, as that Abby also talked about, it can take a long time. So it's also about adapting the way that we're responding as humanitarians. So it's not just the WASH sector, but really working across different sectors as well because of the communication importance. And again, that important point, not only is it regarding cholera, but how we need to be context specific and understand the behavior of people that we're working with. So thank you for that. And we will come back to you in a bit. But Ron, I'm going to turn to you. And working from a health perspective for a long time, and you've worked in numerous health responses, what are your impressions of cholera response by humanitarian actors now, having been through various other responses? I think you're on mute, Ron.
Yeah.
There we go.
Okay, thank you very much, Manisha. What do you mean a long time? Are you saying I'm old?
No, you just have a longer period of experience than many in this room may have.
I hope so, but I do plan on, although most of what I'm about to say does come from the report itself, I think I will bring in a few historical elements that I think are of interest. I was a history major in college, so they're of interest to me at least. I want to thank Humanitarian Outcomes for having taken on this project and included me in it. I think the report is really excellent, well written, well organized, and quite revealing of a number of important elements that are characteristic of where we are with cholera today. Part of the reason that the report was written, as Abby mentioned in her introductory remarks, was a perception that case fatality rates that are being reported are higher than one would like to have. The World Health Organization has set a level of 1% as an acceptable case fatality rate, and they've done this because cholera is an eminently treatable disease. If it's caught on time and treated properly, it should be possible to save almost every life. It's a self-limiting disease. It's a non-invasive disease. It's a disease that people get by ingesting a Vibrio cholera bacteria from contaminated water or food. It lasts normally a few days, and the bacteria should pass through the gut and be excreted by the individual. It's really a question of maintaining a person's, an individual's water and electrolyte balance and preventing severe dehydration from developing. It's the dehydration that is responsible for the death of the patient, as we all know, and not the immediate effects of the bacteria or even the bacterial toxin itself. So I wanted to start by saying a few things about the case fatality rate and maybe repeating a little bit about what Abby said in regard to data, because I've been a little bit confused over the past number of years by the very large fluctuations in case fatality data that we have seen in different settings. Yemen, for example, where there was an enormous outbreak reported in 2017, one that maybe skews the recent incidence of cholera data to some extent, reported a very low case fatality rate. Malawi this year is characterized by reports of a little bit of higher rates than one would like to see. But I think these are really difficult to understand without more detail, without getting into the nitty-gritty of the data itself, because there could be a lot of reporting of community cases, which tend to be milder or moderate, and as I mentioned, self-limited. People can recover. Only a small proportion of people infected with cholera go on to develop severe manifestations of the disease. But data could be being reported from hospitals, for example, where those severe cases will end up and where one might expect a higher case fatality rate. So I think we really have to understand not only the formulas for calculating case fatality rate, but the provenance of the data itself, and pay a little bit of attention to that if we want to be able to make the kinds of comparisons that people have been reporting from year to year, from country to country, from region to region. If the higher numbers that we're seeing are accurate, however, then as Abby mentioned as well, that probably indicates a less than optimal case management approach to these individuals. And case management relies, as I mentioned, almost solely, not completely, not entirely, but almost solely on reestablishing the rehydration status, water and electrolyte balance of an individual. And we do that in most cases. We should be able to do that using oral rehydration salts. There has been a tendency, I believe, as was mentioned, to over medicalize the treatment of cholera and to move in too many cases, sometimes unnecessarily, into more interventionist methods of treatment, such as intravenous rehydration. And there are even some other more aggressive means that have been used in a few places that we don't need to go into here. But I have a feeling that oral rehydration salts as the mainstay of treatment and oral rehydration therapy in general have fallen a bit out of disuse. I've just returned from working in earthquake relief in Turkey and northern Syria, where there have been recently cases of cholera reported. And everyone was very fixated, it seemed, on getting people into tertiary care clinics or higher level treatment facilities so that they could be treated intravenously. I felt at that time, I felt to an excessive degree, and I feel that way because there used to be very, very aggressive training programs when the World Health Organization, in close concert with UNICEF, was running what are so-called vertical programs in the control of diarrheal diseases. And people were trained on a regular basis, 2-week training sessions on how to deal with acute diarrheal diseases, particularly of children under 5, by using oral rehydration therapy and oral rehydration salts. There's not that much of a difference except for the causative agent and the tendency to occur in epidemic form between other forms of acute watery diarrhea and cholera. Cholera is one form of acute watery diarrhea, albeit quite severe in some cases. But the program, the CDD, or Control of Diarrheal Diseases program at that time, was quite expansive on every continent, and it really did do training of even peripheral level health workers, especially peripheral level health workers, in oral rehydration treatment. It tried to minimize the need for more aggressive forms of treatment and minimize the number of cases that needed to be treated at hospital level. Clearly, there's a need for hospital level treatment of cholera, of severe forms of cholera, but as I mentioned, that represents only a small proportion of all cases. Oral rehydration salts, in fact, the first big clinical trial was in a humanitarian setting in West Bengal during the Bangladesh War of Liberation, War of Independence, when Dilip Malanabis, who passed away only a few months ago, treated a group of refugees with oral rehydration salts and a different group with just without treatment at all, with some treatment, but not with the newly discovered formula of oral rehydration salts. The results were that Malanabis was able to attain a 1% case fatality rate in his treated refugees versus a 3.5% case fatality rate in the control group. That trial led the Lancet to call oral rehydration salts the greatest medical advance of the 20th century. I think they could probably get an argument from the penicillin people, but things tend to be exaggerated at times. Malanabis went on to be one of the originators of the diarrheal diseases program at WHO, but oral rehydration salts then became completely established as the treatment of choice for acute watery diarrheas.
Can I ask you, Ron, why do you think it is that there's been that drop in the use of ORS?
I don't know, I haven't really analyzed it. I think it's been so in those days, and I mentioned UNICEF as being part of the program. James Grant, who was a giant executive director at UNICEF, used to go around everywhere with what he used to call his packet in his pocket. And everywhere he went to meet political leaders and leaders from every sector, he would pull out a packet of oral rehydration salts. At that time, a lot of global health efforts were directed towards what was called the twin engines of global health, improving vaccination rates in children and reducing deaths from diarrheal diseases, which were the leading cause of death. And in the report, it states that there used to be at that time over 4 million deaths a year from diarrheal diseases, a number which has fallen dramatically to about 1.5 million deaths of children under 5 now. I think that that's largely due to increases in socioeconomic status, yes, improvements in water and sanitation and hygiene interventions, and maybe, I hope, to improvements in the health sector as well. But we've certainly seen huge changes. So there's also been a huge expansion of available interventions to people living in low-income countries and in humanitarian settings in particular. So the Control of Diarrheal Diseases program morphed into the CDD ARI program that added on control of acute respiratory infection as well. That then evolved into the integrated management of childhood illnesses. That then adopted cholera as well, with the expansion of cholera into South America in 1991. And now we just have so many interventions that we ask people working in peripheral health facilities to take on so many things appropriately. For the most part, I mean, we have to deal with malaria and tuberculosis and everything else, but there's no longer the ability, I don't think, to train people in peripheral level health facilities, to take them out of work for 2 weeks on a regular basis, to give them training and refresher training in diarrheal disease control. So I think it's in some ways a good problem, but I think a problem nonetheless, and especially now that we're focusing particularly on a possible increase in cholera, there may be some reason to crank that up a little bit as well. I don't have much. Let me mention briefly, just in passing, the problem regarding oral cholera vaccine that did not exist at the time that I've just been talking about, but that is a new weapon to add to our armamentarium in the fight against cholera. It's quite important. Unlike oral rehydration salts, it is specific for cholera and does nothing for other acute watery diarrheal diseases. But it is an important addition. And I think it's a shame that we have a tool and we can't use it. We can't use it because it's not available. The production has been interrupted. One of the major producers has stopped production. I've been going around lately telling everybody the answer to all your questions is money. This is another question to which the answer is money. And I think it's really a sad day when we have a reasonably effective, far from completely effective tool, but we can't even deploy it for a problem that everyone recognizes is growing, is potentially fatal, and is difficult to resolve through other means. I wanted to say something about data. I can't ever say enough about data, so I hope somebody will stick that word in the chat box someplace, but I know I've taken up a lot of time, so I'll stop here. Thank you, Manisha.
Thank you, Ron. And I think it's been a really helpful sort of overview of where we've come. And in the Q&A, we've got a couple of comments in response to what you've said. Simon Lawson said, Ron is correct in pointing to the disconnect between routine advocacy and use of ORS for diarrhea treatment, as in UNICEF essential family practices, and for cholera, which somehow are seen as something different. And someone anonymously said, ORS might be the best option for most treatments. However, I doubt that communities are trained and equipped to control the environmental contamination related to sick people, meaning safely managing excreta, vomit, contaminated blankets, etc., when they don't really have functioning latrines, access to soap, bleach, etc. Thus, send people to a CTC, cholera treatment center, is a way to control the epidemic. And yes, there's a tendency for CTCs to go straight away for intravenous rehydration rather than use ORS. So I think there's, as was also mentioned, Nigel, when you were speaking, we need to be able to match the different ways we're coming in. So it's not just the health side or the wash side. We've got to be looking at how people are treating the sanitation side as well. So it can't be siloed. We're going to have a chance to come back to some reflections from Nigel and Ron, but I wanted to turn to Raul and Stanley from, a practitioner's perspective, based on what you've seen in the report and what you've heard from Abby, Nigel, and Ron. Raul, maybe I can turn to you first from a public health perspective. How do the findings of the report correspond to what you're seeing in responses to cholera? And, the elements that Ron mentioned around the lack of ORS being a kind of a primary way of responding, and also this challenge maybe of the vaccine as well, from your perspective.
Yeah, thank you, Manisha, and I really appreciate Ron talk, because it kind of, brought a historical perspective that is quite useful for the participant. And I also want you to congratulate you for the report. It contributes to the advocacy that we as cholera partners are undertaking to rejuvenate the fight against cholera. Someone said that a crisis that is not addressed is a crisis that risks being forgotten. And cholera is an old disease, is a known disease that still remains a significant cause of illness and death in some part of the world. It's quite surprising. So we have to admit that. I just came back from Malawi, where I spent a month with UNICEF supporting the outbreak response, and I've traveled quite a lot in various countries in Eastern and Southern Africa to support cholera preparedness and response activities. I would say that your report clearly highlights some of the challenges that those of us who have been involved in the fight against cholera in many places have experienced. We've seen all the operational challenges to respond to outbreak themselves, and some of the systemic challenges in WASH that Nigel mentioned. And those are the challenges that have slowed down cholera elimination effort. And this cholera context, we have to, the cholera outbreak, the cholera surge is happening in a context that is characterized by multiple crises. These are human manufactured crises or natural crisis. Economic context is extremely challenged. In some countries, we have seen devaluations of currency, rarity of fuel. So we will have competing priorities, even from traditional donors. The crisis in Ukraine attracted, sucked all the money out of the system. That's what we heard. And the humanitarian capacities of responders such as UNICEF, WHO, or the GTFCC, we are stretched to the limit because there are so many fires that we have to pull out that we definitely need to think differently. So we have to rethink our approach to cholera elimination, definitely. We have to rethink our approach to outbreak preparedness. We have to rethink our approach on how to prevent cholera death. And I think the report contributes to the introspection that is currently happening, among the cholera actors, among the GTFCC, among UNICEF and the WHO. So how do we recruit government? How do we, advocate to government to prioritize investment in water and sanitation, in the middle of all the multiple priorities that government have? So how do we mobilize donors around cholera in this, resource mobilization challenge environment? And how do we rebuild community knowledge and community attitude, community practices, trust in government that seems to have been, severely damaged during the COVID-19 pandemic? I'm going to sound like a broken record, but what Ron said is totally obvious. There are some challenges linked to the use of ORS, not because it's scarce, it's totally available. There are some, challenges around some of the cholera commodities, but ORS is definitely not one of them. So there are some challenges around that, totally linked to our community knowledge, attitude, and practices, but also maybe to the limited emphasis that partners have had recently on the use of ORS as a normal part of a toolbox in communities, to use as soon as there's a diarrhea out there. So how do we work on data? Data systems are key to cholera outbreak preparedness and response. So how do we even improve our risks of cholera planning, our risk mapping? So I just want to emphasize the fact that data belongs to government, and sometimes the challenges around cholera data are not limited to cholera. They are part of systemic challenges around data availability, data management, surveillance of infectious diseases in general. So there are definitely something that partners such as the WHO and UNICEF and members of the GTFCC can do. And there have been some movement recently with the development of cholera country plan, or the cholera support platform that is moving to priority country to start looking into some of these specific technical issues that can be addressed, at least in the short term, to respond to cholera outbreaks. I'll stop there. Thank you.
Thanks, Raul. And I see that we've unfortunately just lost Stanley. Hopefully he'll be able to rejoin us. But just on that, your point there around data, there is a question from Alan Kelma in the Q&A. Hi, Alan, it's nice to see you. Who asks, on data, the report highlights two extremes: underreporting due to stigma, and on the other hand, inflated figures due to incentives promised for cholera response. How do we find the balance?
So based on my experience in Malawi, what I've noticed is that we had some challenges in data coming from the community. So the visibility of the cholera outbreak within the community, at least early in the outbreak, is quite limited. So the picture of cholera that you have is based on those cases that come to the facility. So you have this huge reporting bias simply because you catch the severe cases that actually ended up in the facility. And as Ron put it, that may eventually has a role to play in the high case fatality that we have, because of some of the health-seeking behaviors. You have this medical nomadism that may happen and may potentially be linked to a community attitude practices. They will eventually go to several routes before they end up in a hospital or cholera treatment unit with extremely severe cases of cholera. That may eventually explain some of the high case fatality that we see. But overall, I would totally agree that there are still some challenges with cholera data reporting, simply because of some of the system that may not be fine-tuned to capture cholera cases both in the community and in the facility at the same time. Thank you.
Thank you very much. And I think that point about the community knowledge and understanding of cholera also goes back to if there has previously been an outbreak. It's one of the things that was mentioned in some of the research that in some of the interviews is if people have seen it before, they know how to treat it. They know about ORS perhaps, or they know how to respond quickly. But if it's something new, and as we're seeing it in more and more countries, there may be that gap in sort of knowledge that's there a little bit.
Even more to that, Manisha, what we've seen, not only if they've seen the outbreak before, if they've seen the outbreak coming in a different season, that may create doubt. We know that cholera comes, let's say, at the beginning of the rainy season, but if we see it during a different season, that may create that doubt of in the community. Is it really cholera? Totally agree with that point.
Interesting. Stanley, I'm glad you're back. We lost you there for a few minutes, but Stanley, compared to what you're seeing in Malawi, what did you think of the findings of the report and the observations that you've heard from Raul, Nigel, Ron, and Abby?
Yes, thank you so much. Look at the report. The report is a true reflection of
You're frozen, Stanley, so I'm going to just stop your video in case that helps us. I'm sorry about that. Let's see if I'll try to stop your video. Or you might have just frozen. We might have to come back to Stanley, unfortunately. We'll try to come back there. Oh, sorry, Stanley, we lost you there. Could you start again? Sorry.
Okay, fine. All right. What I'm emphasizing now, I don't know if people can hear me. I have internet problem here in Malawi. So there's an internet interrupting somewhere and somehow. So the issue that we really looking at on the study is like it's a true reflection of Malawi context. And one of the issues that is there is like the health promotion. The health promotion is where people are calling out the awareness in the field, in the communities, and let them people aware about the cholera outbreak in relation to hygiene practices and sanitation practices. That's hinting about the rural communities. In the first place, we thought that this issue is hitting the rural masses. At the point now, these issues of the cholera outbreak has hit it in the urban areas than in the rural areas much. And eventually it's when we have realized that the cholera has hit the whole country, and both in the urban and both in the rural areas. It's a different situation than before the situation that we were working on it. Another thing that the study has also not very much hitting into, I think we can demand on the data quality. The data quality must be emphasized that this quality of data must be using the accurate tools. The tools that the specific country, depending on the situation, that we might be valid from one point to another, can be also another issue that we can look at it to improve the little evidence-based at the community levels, and that will show into the little kind of the study that is looking at. In terms of the study, again, we're also trying to look at issues of funding gap. The funding gap, it seems that the project the study did not teaching the sustainable funding way of how donors will be attracted to invest on the aspect of cholera outbreak, specifically on disaster and emergency, which is taken as humanitarian aspect. It seems that many countries are not like what Malawi is all about. They were not seriously look at issues of humanitarian response. We actually look at some other kind of things like HIV/AIDS and malaria, TB. We invested more money on that, but eventually we did not. Our government did not even thinking of investing more monies on the on WASH perspectives. As a result, now the government is now thinking about let's focus on the broader terms where we think about disaster and or humanitarian response to be taken as a priority and to save our people. Look at what is happening right now. There is already a cyclone Fred, which has affected us a lot, and at the same time, the cholera outbreak is also hitting us. So it's like two things at the same time hitting us in the same countries. But when you look at your study now, we are looking at the means of coordination in terms of engagement of the communities. How do we engage the communities? How do we forget the better services that is there? For example, I want to talk about issues of the availability of vaccine, which was being talking and piloted by UNICEF. The vaccine of cholera, yes, we involved being piloted, but certainly we need to do some kind of the analysis. The analysis of the vaccine that was being provided for cholera outbreak was not substantial in terms of the parameters and in terms of the IFs. That might be environmentally friendly or not environmentally friendly. Because there's certain aspects that it seems that like the cholera vaccine did not prevent the infection of cholera. Even though there are some studies that there are some issues on the community that the ORS has helped us than the vaccine that people were tested in the first place to see that this is a little situation that is supposed to be done. So in terms of this community engagement, we need to emphasize as an organization on advocacy to make sure that government must be on top of humanitarian response and to take action in terms of the healthy package. The healthy package could be one of an ideal that will be able to look at holistic kind of approach to look at issues, how we can prevent such kind of the emergency comes in our way, not only prepared for the time when the emergency is hitting us, but we need just to have signals all the time that people might be aware how they can be themselves being protected. And on the study again, I feel there are some issues that also a bit of just need to enhance it is the climate impact and versus the COVID impact. The climate impact and versus COVID impact, you could also try to get that the study will not flash marks on that particular issue, that how does the climate impact related to COVID impact? And those are also resulting into the cholera outbreak as well. Because when you look at the aspect of diagnosis or an assessment, you will be able to say that there's somewhere there's a climate impact, somewhere there's COVID impact resulting into the cholera outbreak that are hitting in our country, like particularly in Malawi, which we have more evidence. And again, the study could also try to not pinch much on the strong partnership. The strong partnership we talk about, that it could be that the donors and the other international NGOs, national and local NGOs, and the health facilities and the government players to coordinate well and to address issues of preventing how best we can prevent such kind of the cholera. We understand that these issues of the perspective of a health promotion could become an issue because that most of the people to understand about health issues sometimes takes simple, but perspectively, The study is really a very good study, but just need a bit of a revision, because one of the things that we look at the study did not also look at the recovery end. So the recovery is also one of the areas that the study should also focus at than the preparedness. So the preparedness, yes, we have done it, but what is the recovery? So you can see now the recovery of the climate change impact, the recovery of COVID-19 impact, and the recovery of the cholera outbreak impact. And all this is in relation to my colleague who was just speak last now from UNICEF, that indeed that the inflation has also impacted in the lives of less developed countries, and as a result, many poor people that are staying in the rural areas, they are more affected. Also, they are even in the urban. They are also more affected due to what? To inflationary aspect that has been really resulting into situation that has really not make impact on the ground. So I think I'm really excited on the study, but I think let's focus on the little evidence-based study, and also a study that can speak to our donors and to be quickly to pour more investment, so that we can together prevent this kind of such incidents. Thank you so much.
Thank you very much, Stanley. And I missed a little bit at the beginning, but I think really you were talking about a lot of the similar things that others have talked about, the quality, the quality of the data. Is it enough? How do we engage government? The financing gap is a really big one as well. But I think this point also on the vaccine and the analysis of, was it as effective as it was we hope it would be, is something to also be looking at. I see we have a lot of kind of questions in the Q&A. Some of them are focusing on the financing aspects. You know, can we talk about the financing for cholera response? And also, oh, I saw another one. I've lost it. Sorry, it might have been answered in the meantime. But I think, you know, how do we also, and also on the data, there's also data challenges related to political decisions that prevent sharing information that could harm economic income from tourism, for example. And then I think maybe on this data one, I think that's an interesting one here, because the data for a WASH response can be different from looking at case fatalities, as Snow and Whitehead found out. Jon Snow, I don't know which Whitehead that is. I'm not a WASH expert. And it's not Jon Snow from Game of Thrones, which is what I thought Ron was talking about when we first talked about Jon Snow from London finding cholera. So I'm not a health expert at all. But I think, how can we help medical staff to collect data such as locations of patients and transfer this to WASH staff? And I guess this comes back again to some of the points that were raised earlier about that perennial divide between health and WASH. Can I maybe throw it back to the panelists and also our other colleagues, Paul Harvey, Paul Spiegel, Glenn Taylor, who's also on here from the report. If anybody has any thoughts of that, how do we kind of make sure that we can share that information across WASH and health a little bit more? And if others in the audience also have any ideas, please feel free to raise your hands and we can promote you to a panelist if you've got thoughts on that. I don't know if anyone wants to tackle that. Abby, please.
Yeah, so in terms of data, there are a couple different levels. We want to look at kind of the global level to see kind of what's happening, and are there really bad trends that have to do with the pandemic? And then there's kind of in terms of local outbreaks, what's happening, and where should we allocate resources and prioritize. Globally, we were not able to ascertain precisely how WHO collects its cholera data. And we don't know about their methods and their controls. What we do know from running global databases is that if you rely completely on voluntary reports, what you will get is a lack of complete capture and inconsistencies in classifications. So there needs to be some more active classification, control, and actually pulling of data, as opposed to this push system. So again, I can't really speak to how they do it. It would be good to have more transparency on that. In terms of sharing locally, it's very frustrating, because when you hear in these kinds of studies that, well, it comes down to personalities, you know that there's real institutional problems. So, we've heard about people like a wash person going over to the health tent and trying to get data in like this one specific area, and data not being shared and this kind of thing. This needs coordination. This needs leadership at the humanitarian level that can really integrate the objectives of the two clusters and break those silos. Yeah, I'll stop there.
Thanks very much, Abby. Anybody else want to come in on this data question, how we might be able to? Nigel, I see you leaning.
Yeah, I mean, just I think some of the work of integrated outbreak analytics is really interesting, where the emphasis they place is not on sort of what data do we need so much as what data is available. So now it doesn't directly address the issue of sharing that Abby was just on about, and people protecting their data or just not finding the time to share their data, but looking at the data that is available and just then doing a bit of a risk mapping approach and sort of saying, well, on the basis of likelihood, these are where we're seeing, sort of the key issues. And to some extent, the WASH practitioners are then going to have to go and look for themselves and engage the communities directly to understand the specific issues. But I think there's probably a lot, we can often let the best be the enemy of the good in terms of the sort of data we're after. And there can often be a sense of, well, the data hasn't reached this kind of quality standard, therefore I won't look at it at all. And I think being recognizing the state of many health systems in many countries, particularly fragile contexts where we see, some of the worst case fatality rates, it's partly about being more pragmatic and using more of a risk lens than a kind of high level of confidence lens.
And we've
Yes,
also got,
Manisha.
Sorry, go ahead, please.
Yeah, thank you, Nigel, for mentioning the integrated outbreak analytics, something that the UNICEF support a lot, and that I've shown is, that have made its proof in places like DRC and currently Haiti. But just on the data, I just want to mention that there are several challenges there. So if we exclude, the systemic challenges that some countries may have to collect data, all kind of data, not only cholera data, that's one of the challenges. Country mostly collect their infectious disease surveillance data through the integrated disease surveillance system. And we know it has its limitation when it comes to, rapidly spreading outbreaks such as cholera. But one of the challenges that we see in the field is that systems are trying to build data collection when the outbreak is happening. And it's really difficult to build a data collection system when we're already in the middle of an outbreak. But I just want to emphasize the fact that the Global Task Force for Cholera Control has some very clear guidelines in terms of what are the data, minimum data element that should be collected for every single cholera cases. And that's very clear. There's no doubt about that. And I also want to emphasize the fact that it's not the role of WHO or UNICEF to collect the data. They are entities supporting and building capacities around data collection and analysis at country level. So it's still the priority, the capacities, the prerogative of the country to ensure that they have timely, complete data that gives clear picture of the outbreak. But one of the challenges that we have, even when countries are able to collect data, some of the sensitivity associated with cholera data. Countries don't have the same, approach when it comes to measles. The data that are shared, case-based, regularly, weekly, monthly to WHO regional office. There's no such lack of sensitivities around measles data compared to cholera data. So we sometimes have in country level these difficulties for countries to share the cholera data even when they are available. So it's happening at all these levels. At UNICEF, we have a package of WASH data that we collect in country as part of the routine program, and even during cholera outbreaks, we have this water testing, this water quality testing with water data that are collected. And we use available cholera data to kind of map all these to make sure that we have a better understanding of the outbreak and prioritize our intervention. So to address some of these challenges, of course, we need a lot of advocacy to go towards government to make sure that to make the government understand that data is totally needed for action. And of course, build capacity for data collection at not only hospital, but also in community. When I say capacity, it's not capacity to collect the data, but also financial capacity, additional bodies to actually collect data, because it doesn't make sense to have someone who is putting IV lines, who is talking to patients, who is providing care, to also be the one filling at the same time all the data form. These are some of the challenges that we saw in Malawi, and we try with the WHO to address this, by providing the support that this country needs. I'll stop there. Over.
Thanks very much, Raul. And I think there's also, Ron, did you want to come in on that? Sorry. No, that's right. I thought you were leaning forward to speak. We also have somebody who's, Lily Seguin was saying in the comments that data, although it's often hard to come by in a timely and reliable way in the first place, there's also the issue of timely sharing, even if it does exist between WASH and health actors for all kinds of reasons. And it's still a recurrent issue. So I think these divides that we often see is something that we really need to be working on a little bit. There are a couple of questions, or at least there's a couple of more specific questions. One around the oral cholera vaccine from Sapna, who's saying, very interesting discussion so far. Could any of the panelists expand on the discussion on the use of oral cholera vaccine in outbreaks and/or in populations at risk, especially in light of the supply issues, and also in terms of what, Stanley, you mentioned in terms of the analysis that may be required, whether or not it's actually as effective as we hope it is. There's that one, and I'm going to also throw out the other one that Jenny Lamb has posted around the ORS element being a key tool in the key in the toolbox of interventions. Do we have an idea per country or region the supply chain aspects of ORS sachets, i.e. a regular market assessment? We also need to relate this to people's affordability to buy ORS when most struggle to buy and prioritize soap for hand washing, for example. Sugar salt solution is a good alternative, but often the likes of sugar is not available or expensive. Market assessments and monitoring are key in a cholera response, which are often missing. And I guess that point also comes back to, is it the WASH actors or the health actors that would do those market assessments, or is that something that we could be doing more generally with other actors who may be doing market assessments, like those who may be looking at food security? I don't know if anybody on the panel has any thoughts around either the oral cholera vaccine or the questions around ORS. Ron, please.
Sure, I can try to address the second half of the ORS question and the first part of the vaccine question, or maybe the full vaccine question. But in regard, I can't speak to the supply chain issues that were mentioned. I don't think, I've never encountered problems with ORS supply. I think that it was mentioned earlier that there aren't, it really hasn't been a problem historically speaking. It should be there. I would take some issue when it comes to cholera in placing a great deal of reliance on sugar salt solution as opposed to ORS. In cholera particularly, the electrolyte losses can be severe, and ORS is a much better medicine than sugar salt solution for cholera specifically. The difference may not be quite as great or as important when it comes to other forms of acute watery diarrhea, but cholera really should be treated with the entire range of electrolytes that individuals are at risk for losing because of the pathophysiologic mechanisms by which cholera does its work. The same is true even on the intravenous route. I'll just add from a little bit of a medical perspective, but an intravenous drip of 5% sugar and water is just not nearly as good as the recommended Linger's lactate or Hartmann solution. That is a much more complete range of electrolytes that replace the losses much better. So I just wanted to say that. In regards to the
Ron, could you just, for those of us that don't know what that is, could you just clarify that for those
yeah, I'm
non-health
just saying,
experts?
so cholera, what happens in cholera is that the bacteria, let's go of a poison that affects the cells of the lining of the intestine. And there's a lot of mechanisms that regulate the balance of water. And by electrolytes, I mean things like sodium, potassium, bicarbonate, chloride. There's a whole range of molecules that are engaged in going back and forth across the intestinal wall in the normal processes. But this poison that the cholera bacteria elaborates kind of locks this pumping mechanism in the going out position. It doesn't allow for the intake of these of water and electrolytes. It locks it so that the flow becomes unidirectional, that is from the body to the intestine, which is basically like the outside, because it's open to the outside at both the top end and the bottom end, right? So you're just losing, and the volume of losses can just be phenomenally great. So that the phrase in the cholera world is that people can wake up, eat breakfast in the morning, and be dead by lunch, which is true for severe case of cholera. And they need to have both the water and these other components of the system replaced. So that's a quick, way too quick update on what happened. So sugar salt solution was heavily promoted. It actually caused a lot of friction between UNICEF and WHO in the 1980s. UNICEF wanted to give people in communities something better that was not a commercial product that they could do on their own, empower them to deal with a very important cause of diarrhea. And that was great in most instances. But in forms of severe dehydration, and particularly the kinds of severe dehydration that cholera can cause, there's a clear preference for the full formula as opposed to the handmade sugar salt solution. So enough on that. The vaccine questions are interesting. I didn't quite understand how WHO has clear guidelines for the use of cholera, both in endemic countries and during epidemics, for the prevention of and response to epidemics. And I think those hold pretty clearly. I find the cholera issue now to be quite problematic because of the decision from the ICG, which I forget what it stands for, Abby might remember.
International Coordinating Group.
The International Coordinating Group, to say that because of the interruption in the supply chain and the fact that there's less oral cholera vaccine available, that they have said that they would only give the vaccine to countries if countries would use a 1 dose as opposed to a 2-dose vaccination schedule. I'm sure that that has a major impact on the perceived effectiveness of the vaccine in the field. The vaccine's not great. It's not the best. It's not measles vaccine. It's not many other vaccines. It's a good adjunct to treatment, but it cannot be used to rely upon completely. But what I wanted to mention was that if you take a country like Haiti, which had its first outbreak of cholera only 13 years ago, it means that they vaccinated, and everyone in Haiti who's over the age of 13 has been fully vaccinated. So pretty much, I'm exaggerating a little bit. The vaccine doesn't last forever, so there's been a waning of protection. But what the Ministry of Health in Haiti wanted to do was to say, we don't want to use a single dose vaccine because most of our population has received several doses of vaccine already. What we'd like to do is give a full course of protective vaccine to younger people up to the age of 15. We want to give 2 doses up to the age of 15, and we won't vaccinate adults. And the ICG refused on that. The ICG said, no, we're only offering the vaccine if you promise to stick to a 1-dose schedule. I found the epidemiological argument of the Ministry of Health in Haiti to be pretty convincing, to me at least. And I thought that the countries should have the ability to use the doses of vaccine that they're allotted in a way they seem fit and that seems better for the epidemiological situation that they have locally. I don't think this is something that needs to be dictated. So there are other issues involving vaccine. There was another question that talked about the reluctance that countries might have to report cholera because of the political damage it might do. And yes, absolutely. In 1991, when cholera came to the Americas, Peru reported cholera to the World Health Organization, and immediately they were basically crippled. Their tourism industry was crippled. Their seafood export industry was crippled because there were sanctions put on them, travel restrictions from some countries to Peru, import sanctions on their products imposed by the European Union. So they were punished for that basis. And that's one of the reasons why we have the revamped international health regulations now, to which every country is party, and why, when that was found to be not enough during the COVID pandemic, negotiations towards a new pandemic treaty occurring now that should be binding on all countries, and it's meant to encourage the most rapid and complete reporting possible. So it's not there. It's definitely not there. The points made are good ones.
I guess that maybe is a good sort of segue to sort of think about, how do we move forward? And I know, Raul, I had a question for you, and then I jumped to the Q&A, but Raul, how do you think some of the proposed areas for action in the report, and also some of the things that have been discussed today, can be taken forward, and what else, who should be doing it, and what else needs to be done?
Yeah, thank you, Manisha. And I think the 7 areas of action that you have identified in the report, are very relevant, and they are relevant today as they were relevant yesterday. And I like in the report the fact that you acknowledge that some of the triggers of cholera lie completely outside of the humanitarian actors' intervention. So if you mention, development, because cholera is definitely a disease of underdevelopment. When a country develop, they don't have cholera. We have to mention, conflicts, climate change. The long-term solutions, to cholera are totally under the control of non-humanitarian actors. As humanitarian actors, WHO, UNICEF, we respond to humanitarian needs. So I think it's important to mention that. And I would say that, unfortunately, the current cholera situation poses a kind of dilemma, where we have to balance between immediate humanitarian response, because people are actually dying, to focus on our regular development or long-term activity. So we have to stop now to respond to an outbreak, prevent people from dying, and by focusing on emergency, we cannot actually look at the things that will make sense in the long term. So how do we, make a difference when we are focusing on humanitarian response? So how do we anchor our response in the areas that are known to yield the largest dividend when it comes to outbreak response, for example? Can we build capacity? Can we improve data quality and availability, set up good data system? Can we build stronger coordination mechanism, including cross-country, coordination, cross-border collaboration? Because cholera is definitely more than country issues. They are, regional challenges. Can we, do better risk mapping? Can we, come up with more flexible funding? And so we all have, as humanitarian partners, kind of skin in the game. So considering that there's strong disruptions of cholera outbreak when they happen. So I would just say that the time to act is now. All the humanitarian partners, so the WHO, UNICEF, the GTFCC, we are part of it. But of course, we don't want to forget about the bilaterals, the donors, the multilaterals partners. So really, frankly, as the UN said, access to water and sanitation is recognized as a human right, and I think we have to adhere to that. I'll stop there. Over.
Thank you very much, Raul. And I mean, I think that issue about the coordination, not only between humanitarian actors and the development actors, and as you said, you know, if we did have development in a lot of these countries, then it wouldn't be a case. But that challenge also of having to respond is one that's there. Stanley, before I kind of look at that, if there's the last kind of questions, I mean, from your perspective, working in Malawi, you've already identified a number of the challenges that you're facing. But what do you think needs to change, particularly in terms of international response capacity to respond to cholera?
Okay, thank you so much for that question. On Malawi context and perspective or international perspectives, I feel that in this study, we're looking at the strong partnership. The strong partnership, it emphasizes on the issues of community engagement, the community actors, and the advocacy issues must be taken into consideration, and the collaboration with the many stakeholders within the area, from the regional level to the district level and up to the country level as at large. And also the emphasis point could be the quality data. Sometimes we conduct a study at regional level, or they might be specific into a context of what.
I am trying to stop your video, Stanley, because we've lost you again, unfortunately. Maybe I will try and come back to you as we try and stop your video and see that. In the meantime, maybe there is a question from Susan around, are there any efforts to understand how the effects of climate change will continue to change in their influence on the incidence of cholera and the ability to respond in humanitarian emergencies in terms of the ability to prioritize vulnerable populations experiencing or susceptible to an outbreak? And have these potential geographic regions been identified? Are they being prioritized to identify where cholera may occur next? I see, Raul, you're nodding. And then Stanley, I'm going to try and come back to you.
Yeah, totally. We know that the climate situation is definitely not going to get better. So, and this is something that at UNICEF we are integrating in our programming when it comes to not only cholera, but also all the vaccine preventable diseases or any pathogen that may, change its geographical distribution because of climate. And we work with partners to not only use current and focused, data or information about climate change, but we integrate these in our, let's go horizon scan or hotspot mapping. We know that in some places we'll have more floods and eventually, population movement or destruction of wash infrastructure. So we kind of integrate some of these climate component into our programming about cholera, and we come up with a kind of prioritization of countries that we may potentially have to focus on in terms of our programming around cholera preparedness and response.
Super. Thank you very much, Raul. Stanley, I'm going to try to come back to you. I've turned your video off in the hopes that that might improve the connection for you.
Okay, good. Yes, I think I really emphasize the point of the evidence-based kind of the research where we integrate aspects of COVID-19 impacts, climate change impacts, and these issues are very, very important in this study. Why is the emphasis on evidence-based? Because most of the studies sometimes are more scientific. When you got the report of a particular study, you do see that many people are not getting a benefit of what the study is all about. So I would really love that this study, as the final report has come out, should be more specific into practice, not into a scientific aspect, where people will take, the donors will take those action into practice to prevent the cholera outbreak or humanitarian response. Despite that, we need also to emphasize issues of health promotion as a public health aspect. One of the issues that in public health could be focused on health promotion. This health promotion would be a continuous awareness in sanitation, in hygiene, and also in advocacy, and also trying to bring some signals of disaster and emergency preparedness that would affect our people both in the urban, both in the rural areas, that we must be all aware, and also developing the program, maybe on the radio, on the Twitter, on WhatsApp, just to let each other know that some of these outbreaks might be under the way or on the way to affect us, and how do we prevent such kind of the issues. So I'll really look at that aspect to look into more pertinent and more practice aspect that we should think about it. And the last point could be the funding, sustainable funding. And we know that because of COVID-19 impact, many economic or kind of issues has affected globally, but we may also ask that more local partners must be engaged, empowered, trained, so that they must be act, not waiting for, like, for example, waiting for UNICEF to come into the country and to start responding, rather than that we have a strong network capacities that we can respond to the issues, that we can change our lives of the people in the areas. We don't need a thing on this study. We don't need a short-term investment. As of now, the way how the indicators in Africa and including Malawi, the way how the issues, the outbreak has hit us, including COVID-19, we need a long-term sustainable investment measure to address these issues for a long-term programming. Thank you so much for your question.
Thanks very much, Raul. I realize we're coming up on the end. We've got about 5 minutes left, but I just wanted to point out that there's a couple of comments that are still there. Simon was 100% agreeing with you, Raul, around the development of the provision of safe sanitation through sewage and safe water through water treatment works is what eliminated cholera from London and Paris, not behavior change per se, but rather development of an enabling environment. And I think, as you mentioned before, also, it's really about how do we make sure that sustainable development is there. And that there is a point in the chat also from Dr. Fiston Balola from the Democratic Republic of Congo Red Cross, saying that they have a lot of experience, but also a lot of challenges in the responses against cholera. So it's very important in difficult contexts to listen to those who are already working there. I just wanted to see if anybody on the panel has any 30-second points to make before I just wrap up and thank everyone. Anything we've forgotten? Abby?
Just to briefly say, we were talking about it in the Q&A, but as Stanley was saying, there's this lack of long-term investment. And when that happens, you are faced with humanitarians trying to deal with these chronic problems with humanitarian modalities and solutions, which are, especially in funding, tend to be short-term, reactive, inflexible. So what some parties are beginning to experiment with is more risk-responsive solutions. And I think there's a lot of promise to that concept, but it's only in the early stages.
Super. Thanks very much, Abby. Glenn, please.
Abby just made the same point about funding and risk. I think my part in this was quite minimal in the sense I was trying to, not necessarily look at the cholera component, but linkages to other sort of trends, in the bigger system. And I don't think that you can. This is a devil's advocate position. I think one has to look at how the funding trends lower for this type of work and this type of capacity building in cholera may be linked to sort of on the donor side, on the big agency side, changes in sort of conceptualization of what the humanitarian system is for. And I don't think, if I was to take a stab, I would say that the chance of this getting a reversal in funding of huge investment in this sort of area would seem to be against the trend. So the question is then what under these circumstances? A cheerful note to finish on, sorry.
Nigel, 30 seconds because we've got only a minute left, please.
Yeah, so actually it's going back to the point Simon Lawson made. I think I would argue it's about behavior change and the ability to enact that behavior. So there's an interesting study Oxfam did whereby 40% of women in refugee camps were not using the latrines provided because a range of sexual harassment and other issues to do with those latrines. So it's about behavior with being able to adopt the behavior because you've got safe access to things. So again, it calls to this integrated approach of whether it's health, wash infrastructure, or behavior.
Super. Thank you very much. Huge thanks to everybody. I think it's been a really interesting conversation to kind of pick up on the findings of the report. We've very much seen that there are some major challenges facing the response to cholera, the divide between health and WASH practitioners, the inability to share information on a regular basis, the data gaps that we have, the data that may be coming out of the fact that we're only seeing data after cases are severe, the lack of communities not necessarily having the experience of dealing with cholera or finding that it's not in their usual season, so not being able to respond in the same way. The lack of the vaccine, not having enough of it, the shortage, and how do we make sure that we get more providers of that? But then how do we make sure we go back to the 2-dose regimen? Really looking at how do countries then are able to get access to the vaccine, but that really also needs to be complemented much more with ORS and that more traditional and more effective way of treating cholera when it does arise. The issue that humanitarians are responding when development actors have not been putting the money in there, that sustainable development is a huge challenge, and the fact that we have so many more humanitarian crises combined with the impacts of COVID and climate change make it such that we see cholera more often, but we also see the financing going down. And I think that's something that came out across the conversation today, is that we need more money for humanitarian response, but also for cholera response. And that anticipatory funding, as soon as we sort of see something that could be cholera, putting the money there early on will help much more than trying to address it once there's these huge outbreaks. As Stanley, you pointed out, once it became across both urban and rural areas in Malawi, it's much harder to respond to. I think that point also about how do we really involve communities and do that community engagement so that we've got that behavioral change is really critical. But I think at the end of it, given that we've got so many more countries experience cholera, the risk of it rising with climate change and the various humanitarian crises we have, means that we do have to work across our different sectors, but also really push for development actors and development financing to come in much more. One of the hopes with COVID had been, that emphasis on WASH would continue and we'd have much more investment, but unfortunately that hasn't happened. So the advocacy really needs to continue there as well to make sure that that longer term investment is there for both the health infrastructure, but also for WASH and sanitation. And given that it is a human right, as you pointed out, Raul. Huge thanks to all our speakers, Abby, Ron, Nigel, Stanley, Raul, but also everybody else on the team, Elra for hosting, the UK FCDO for funding the study through the Humanitarian Innovation Hub, to all of you who joined us today and asked lots of questions. Hopefully the study will be useful, and this conversation is just the start of really trying to move things forward. Sorry for going over a couple minutes, but I hope you all have a wonderful rest of your days. Thank you.
Thank you.